بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the lecture number 7 in the series of Diagnostic Radiology in English, DRE. And it will deal with the imaging of the posterior fossa as a part of the series which are titled the brain imaging. Actually, you know that the posterior fossa is a part of the intracranial structures, and all what can occur supratentorial can occur also infratentorial in the posterior fossa. But dealing with the posterior fossa, we have a certain approach which is related to anatomy rather than to pathology. And we divide the posterior fossa into 4 main anatomic locations, which are: number 1, the region of the fourth ventricle; number 2, the region of the brain stem anterior to the fourth ventricle; number 3, the region of the cerebellum posterior to the fourth ventricle; and finally the cerebellopontine angle region. And we'll start first by lesions that can occur in the region of the fourth ventricle, and we have discussed in the lecture of intraventricular tumors most of these lesions, but we have to emphasize these two important tumors, which are the ependymoma and the medulloblastoma. Then, as you all know, that the ependymoma occurs mainly in the fourth ventricle in the pediatric age group. It represents about 10% of the pediatric intracranial neoplasms and about 9% of all gliomas of the grade 2 or 3 WHO classification. The age incidence of this ependymoma ranges from 10 to 15 years and is very common in children compared to adults. And you know that the best prognosis for ependymoma is for that occurring in the filum terminal, followed by intramedullary ependymoma, followed by the supratentorial lesions, then finally the posterior fossa ependymoma occurring in the region of the fourth ventricle. The classic appearance of ependymoma and the CT images is an isodense mass filling the region or centered to the region of the fourth ventricle. And the presence of calcium is one of the important criteria of this particular type of tumors. And if you inject contrast media, the tumor may show homogeneous or heterogeneous contrast enhancement. And of course, the presence of hydrocephalus is common due to obstruction of the CSF flow through the fourth ventricle. Also, you can see some cystic changes in these tumors in about 15% of cases, and it is one of the most common lesions that can metastasize through the CSF, what is known as the CSF seeding or seedling. And in these images, you can see a well-defined midline posterior fossa space occupying lesion centered to the region of the fourth ventricle, showing homogeneous post-contrast enhancement and foci of matrix calcification. The lesion obstructs the fourth ventricle with consequent supratentorial obstructive hydrocephalic changes. And this is another case of an ependymoma centered to the region of the fourth ventricle showing matrix calcification. And you can see the incidence of calcium in these tumors, which may reach up to 50% of the cases. And this tumor has a particular way of spread. It can extend through the fourth ventricular foramina, and it can extend also high up through the aqueduct of the sylvius, as well as through the outlet foramina of the fourth ventricle. And this is one of the peculiar imaging finding of ependymoma. And you can see a tumor. These are MRI T1 weighted images post contrast, and you can see a specific lesion almost homogeneously enhanced center to the fourth ventricle, and you in these images you can easily identify the extension of the tumor through the foramina of the fourth ventricle. One of the characteristic findings of ependymoma occurring in the fourth ventricle, and this is the case of ependymoma in the region of the fourth ventricle with metastatic CSF seed. And you can see the enhancement of the basal cisterns and in the nodular enhancement in the suprasellar area, as well as around the brainstem in the circummesencephalic cistern. And this is also a case of ependymoma by MRI, T2 and T1 post contrast, axial and sagittal images. And in the sagittal images, you can also see one of the characters of ependymoma, that it is filling most of the fourth ventricle and extends through the outlet foramina of the fourth ventricle as well. An ependymoma by MRI will show a hypointense signal or isointense signal to the brain parenchyma in T1 weighted image, with hyperintense signal in T2 weighted image, as you can see here. And also this is the FLAIR image, where you can see high signal of the tumor, which is centered to the region of the fourth ventricle. After contrast injection, the tumor may show homogeneous or heterogeneous post-contrast enhancement. The tumor vessels can be seen along the margin of the tumor, as well as low signal foci of calcium may be identified also within this type of tumor. Also note that this tumor usually totally occupies the fourth ventricle, especially its upper segment, and this can differentiate ependymoma from the medulloblastoma. Then we came to a second well-known tumor in the posterior fossa, which is the Bennett or the primitive neuroepithelial or neuroectodermal tumors. And these are a group of tumors formed of undifferentiated cells resembling the germinal matrix cells found in the neural tube. And these tumors generally occur in the pediatric age group, and they include a group of heterogeneous lesions including the medulloblastoma, retinoblastoma, ependymoblastoma, medulloepithelioma, and the cerebellar neuroblastoma. One of the best examples for these tumors is the medulloblastoma occurring in the posterior fossa, and this is the age incidence about 5 to 9 years, is slightly lower than the incidence of the age incidence of ependymoma. And this is a highly malignant lesion with CSF dissemination, and it may produce metastasis outside the CNS, especially to the bones. Then if you see a lesion which is occupying the region of the fourth ventricle, it may show homogeneous contrast enhancement, and sometimes it contains calcium. And this is the medulloblastoma, which arises from the roof of the fourth ventricle, and this area is the roof of the fourth ventricle. Then the tumor will protrude inside the fourth ventricle, as well as involves the adjacent cerebellar parenchyma. These tumors occur in the midline posterior fossa region in most of the cases, but in adults it may occur outside the midline in the cerebellar hemisphere itself. And these are two examples of medulloblastoma by CT and by MRI T1 post contrast, and you can see the enhancement of the tumor, and the incidence of calcium is less than ependymoma. This is 15%, and ependymoma is about 50%. Then cystic changes are here more common, and the CSF seeding is a well-known feature of this medulloblastoma. This is the medulloblastoma by MRI, and you can see this is the FLAIR image, a relatively mild increased signal of the tumor. And the T1 weighted image, the tumor is almost iso-intense to the brain parenchyma with homogeneous post-contrast enhancement. And you can see the difference between ependymoma and the medulloblastoma in the sagittal images. And the ependymoma usually fills the fourth ventricle, especially this particular area, which is the upper segment of the fourth ventricle, while the medulloblastoma usually does not fill the whole fourth ventricle, especially its proximal, its upper part. And this is an example of medulloblastoma, which is considered the most common posterior fossa tumor in children. And you see this is T1 weighted image, and you can easily appreciate the cystic component of the tumor. After contrast enhancement, you see enhancement of the solid component and no enhancement of the cystic component. And in the sagittal images, you can appreciate the tumor, and you can see that it does not fill this proximal segment of the fourth ventricle. And this is an example of medulloblastoma by CT with a homogeneously enhanced lesion centered to the fourth ventricle with proximal obstructive hydrocephalic changes, and here you cannot see matrix calcification. Then, in the region of the fourth ventricle, we have two main important tumors, which are the ependymoma and the medulloblastoma. Then we came to the cerebellopontine angle lesions, and these lesions include the acoustic neuroma, the meningioma, the epidermoid cyst, and some other lesions. Actually, in order to deal with a cerebellopontine angle lesion, we have to discriminate between intraaxial tumors occurring inside the brain parenchyma, particularly in the middle cerebellar peduncle, and extraaxial lesions occurring outside the brain parenchyma in the cerebellopontine angle system. And most of the tumors are extraaxial, and some of the lesions are intraaxial. In order to differentiate intra from extra, look at the cistern ipsilateral to the lesion. If you see widened cistern on the same side of the lesion, and this is an extraaxial tumor. If you can see obliteration of the cistern ipsilateral to the lesion compared to the opposite side cistern, then consider this is an intraaxial tumor. And this is the difference by MRI. This is MRI T2 weighted image of a brain stem tumor obliterating the ipsilateral cerebellopontine angle cistern, while this is the case of a cerebellopontine angle meningioma compressing the brainstem and causes widening of the ipsilateral cerebellopontine angle cistern. Then the most common cerebellopontine angle tumor is the acoustic neuroma, and it represents about 90% of the cerebellopontine angle lesion tumors and about 85% of all intracranial neuromas. This is a tumor of adults, and the females are relatively the incidence in female is relatively more common, and it is also seen in type 2 neurofibromatosis, where you can identify bilateral acoustic neuromas. Then one of the diagnostic landmarks of this tumor is that it has an intracanalicular extension inside the internalization canal. The diagnosis of acoustic neuroma before the era of MRI was depending mainly on the CT scan. And here you can see a patient with right-sided sensory neural hearing loss, and you can see obliteration of the internalization canal by enhancing a small lesion compared to the left side internalization canal, which is filled with CSF. Then, in order to confirm the diagnosis of an intracanalicular acoustic neuroma, we used to do a technique which is now obsolete, known as air cysternography. We inject air through a lumbar puncture, then we let the patient lie on the opposite side of the lesion, letting the air to accumulate around the orifice of the internal canal. If there is no tumor, air will enter with the CSF inside the internal canal. If there is a tumor like this, in this case, the tumor will prevent air from entering inside the internal canal. But nowadays, we only have an MRI axial or coronal T1 post contrast. Then you can see the tumor, which is filling the internal canal with a small extra canalicular extension. And very small intracanalicular acoustic neuromas can be easily identified by MRI T1 weighted image, and especially the T1 post contrast. And here you can see a very small lesion inside the left internal canal, and after injection of contrast, then you can see significant enhancement of the lesion. And in this patient, you can feel that this right internal canal does not contain the CSF, or in the T2 weighted image, the detection of the lesion is difficult. But in the FLAIR image, where the CSF is black and the tumor is bright, then you can easily identify the lesion inside the left internal canal. And after injection of contrast media, then you can see the tumor filling the left internal canal, diagnostic of an intracanalicular acoustic neuroma. And then acoustic neuroma is an extraaxial lesion. It will widen the ipsilateral cistern, and it shows intermediate signal in the T1 and T2 weighted image. And after injection of contrast, it may show homogeneous or heterogeneous post-contrast enhancement with the classic appearance of extension inside the internal canal. And in cases of neurofibromatosis type 2, you can identify bilateral acoustic neuromas extending inside the internal canal, as well as other lesions in the brain. And here is an example of bilateral acoustic neuroma in a patient, female 16 years old, with neurofibromatosis type 2. She had bilateral, almost symmetrical acoustic neuromas centered to the orifices of the internal canal. And this is an example of an acoustic neuroma by MRI, low signal in the T1, high signal in the T2, and homogeneous post-contrast enhancement with intracanalicular extension. And this is another example in the FLAIR or proton density image and T2 weighted image and T1 post-contrast. You see the enhancement of the tumor and intracanalicular extension. Then you know that schwannomas have an incidence of cystic changes compared to those of neuromas. And this is an example of a right-sided cystic acoustic schwannoma before and after contrast enhancement. And you see the cystic changes within the tumor. The bone window shows mild dilatation of the right internal auditory canal. And this is also an example of cystic schwannoma in the left cerebellopontine angle region. In the T2 weighted image, you can see the cystic changes of bright signal due to the fluid content, and after contrast enhancement, you see enhancement of the solid part and no enhancement of the cystic component. And in this image, you can appreciate the extension of the tumor inside the internal auditory canal. And this is also a case of left-sided cystic schwannoma, showing a big cystic component and a small enhancing solid component. Then we came to the meningioma, which is also seen at the cerebellopontine angle as an extraaxial tumor, as you can see here, with widening of the ipsilateral cerebellopontine angle cistern. And this is a good example of meningioma at the cerebellopontine angle region. It shows homogeneous post-contrast enhancement. Its main central part is not centered to the orifice of the internal canal, with no evidence of tumor extension inside the canal itself. And this tumor is based to the tentorial leaflet, as you can see. And in such a particular location, there is one of the differential diagnoses, which is the aneurysm of the tip of the basal artery. And sometimes you can see a homogeneously enhanced lesion here representing an aneurysm of the tip of the basal artery. We'll discuss this in the lecture of intracranial vascular lesions. And in order to differentiate between both, it's an easy process, where in cases of meningioma you can easily identify the basal artery, while in cases of aneurysms you cannot usually identify the basal artery in this area. And this is the case of cerebellopontine angle meningioma on the right side. It shows intermediate signal in the T1, high signal in the T2, and homogeneous post-contrast enhancement with characteristic dural tail. And there is also a supratentorial extension in the paracellular area, as you can see here. Then we came to one of the famous cysts occurring at the cerebellopontine angle region, and we discussed it in the lecture of intracranial cysts. It is the epidermoid cyst. And you remember the incidence is 2% of brain masses, intracranial masses. It is a hypodense lesion of CSF-like density, and it may simulate arachnoid cyst. The differentiating points between epidermoid and arachnoid include the location. Epidermoid cyst is commonly located at the cerebellopontine angle region, while the arachnoid cyst is seen against the greater wing of the sphenoid. Arachnoid cyst has a smooth margin, epidermoid cyst has a lobulated appearance. Arachnoid cyst does not show calcium, epidermoid cyst may show mural calcification. Arachnoid cyst will follow the CSF signal in all pulse sequences, while the epidermoid cyst will not appear black in the FLAIR images like the CSF. Also, in the diffusion weighted images, you may arachnoid cyst will show free diffusion, while the epidermoid cyst will show restricted diffusion. And this is a good example of epidermoid cyst at the right cerebellopontine angle region in the T1 weighted image, and in T2 weighted image, T1 post contrast. The epidermoid cyst will not enhance, also the arachnoid cyst will not enhance. And in the FLAIR image, the epidermoid cyst will not show a signal similar to that of the CSF. And in the diffusion weighted images, the epidermoid cyst will elicit restricted diffusion. And here is a small epidermoid cyst occurring at the left cerebellopontine angle region, and you can only see this cyst in the diffusion weighted images, because in the T1 it is almost similar to the CSF, also in the T2, and after contrast enhancement it will not enhance. Then the diffusion weighted image will show the cyst with restricted diffusion, as you can see. Then you can see this cyst at the cerebellopontine angle region with extension supratentorially in the circummesencephalic cistern. It shows low signal in the T1 and high signal in the T2. But in the proton density, which was used before the development of the FLAIR images, you can see that the signal of the lesion is almost similar to the signal of the CSF, diagnostic of an arachnoid cyst. Then we came to the third location, which is the cerebellar hemisphere, and the cerebellar hemisphere may show hemorrhage, may show infarction, may show some of inflammatory lesions, brain tumors, calcification, and cysts. And you should know that the cerebellum is the second most common site for hypertensive bleeding after the temporoparietal area, and this is an acute right cerebellar hematoma extending into the fourth ventricle with some obstructive hydrocephalic changes supratentorially. Then hemorrhage in the cerebellum will be the same as hemorrhage in the cerebral hemisphere. This is an acute hematoma by CT. By MRI, you see part of the hemorrhage is of intermediate signal in the T1 and very dark signal in the T2, denoting deoxyhemoglobin, acute blood. And part of the hematoma will show high signal in the T1 and dark signal in the T2, denoting the subacute, early subacute blood intracellular methemoglobin. And this is the subacute cerebellar hematoma, right side showing high signal in the T1 and high signal in the T2 with the low signal hemosiderin margin, as you can see. Also, cerebellar infarctions are common in the pica territory, the posterior inferior cerebellar artery, where you can see a hypodensity by CT. It may exert a mass effect on the fourth ventricle, and it may also cause some supratentorial hydrocephalic changes. Here is a pica acute infarction, and you can see the T1 low signal, T2 high signal, and in the diffusion weighted images you can see the restricted diffusion. And this is also a cerebellar infarction in the pica territory, low signal in the T1, high signal in the T2, and the FLAIR weighted images. And cerebellar abscesses are common, especially those occurring near the cerebellopontine angle due to extension from ear infection. But any site of the cerebellum can show abscesses, and we'll discuss the intracranial infection in a separate lecture. But you know that abscess will show uniform margin of irregular thickness and contrast enhancement. Also, tuberculomas, which may simulate very small abscesses with thick enhancing margin and central hypodensity. They are usually surrounded by brain edema if they are acute. This is a good example of multiple cerebellar and cerebral tuberculomas. And here is an example of posterior fossa subdural empyema, and you see enhancement of the dura bordering this hypodense collection by CT, and also you can identify some ear loculi inside. And commonly these lesions are coming from extension of ear infection into the posterior fossa. Then we came to the tumors, and you remember from the lecture of brain tumors we have meningioma and lymphoma showing homogeneous enhancement, astrocytomas different types, metastasis, and this hemangioblastoma is a tumor which is occurring in the posterior fossa. And meningioma in the posterior fossa may occur at the cerebellopontine angle or along the cerebellar convexity or based to the tentorial leaflet. And this is an example of convexity meningioma showing homogeneous post-contrast enhancement in this MRI axial T1 weighted image. And here is an example of tentorial meningioma, a homogeneously enhanced lesion based to the right tentorial leaflet. And also lymphoma commonly occur in the supratentorial area, but can also appear in the posterior fossa. And this is a good case of lymphoma showing multiple homogeneously enhanced periventricular lesions surrounded by mild perifocal brain edema in the supratentorial area as well as in the cerebellar vermis. And this is lymphoma. Pilocytic astrocytoma, we have mentioned a lot about this tumor, which is a common lesion occurring in the posterior fossa, characterized by a cyst with an enhancing mural nodule. And you remember that the cyst may contain septations, and the nodule may occur in one of these septa. Then the pilocytic astrocytoma is a common lesion in the pediatric age group in the posterior fossa, showing a cystic component and an enhancing solid mural nodule. And this is also another example of a large pilocytic astrocytoma showing a solid component and a cystic component in the right cerebellar hemisphere. Then pilocytic astrocytoma, low signal in the T1, high signal in the T2, and homogeneous post-contrast enhancement of the mural nodule. The cyst wall may enhance, as you remember, and also the internal septation may enhance, but commonly the cyst wall does not enhance in these particular tumors. Then we came to a tumor which is almost similar to the pilocytic astrocytoma, which is the hemangioblastoma. The hemangioblastoma is the cyst with an enhancing mural nodule, and it represents about 1 to 2% of the primary intracranial neoplasms, and about 10 to 20% of these lesions are associated with von Hippel-Lindau syndrome. The difference between hemangioblastoma and pilocytic astrocytoma are: number one, the hemangioblastoma occur in adults, and it is rare in children, while the pilocytic astrocytoma is common in the pediatric age group. The hemangioblastoma is located mainly in the cerebellar hemisphere in about 85% of the cases, and about 15% of the cases are located in the spinal cord. Then the hemangioblastoma will appear as a cyst with an enhancing mural nodule. And the difference between it and pilocytic astrocytoma is that the mural nodule is hypervascular in cases of hemangioblastoma. Then if you have an angiogram, you will see the mural nodule showing homogeneous tumor blush with tumor neovascularity surrounding the site of the nodule. And here is the hemangioblastoma, which is almost similar to a pilocytic astrocytoma. And you can differentiate by the age of the patient and by the clinical picture and by the strong enhancement of the nodule in cases of hemangioblastoma. And if you have an angiogram, you will find this nodule is hypervascular. Then this is a good case of hemangioblastoma occurring in the cerebellar vermis, showing a solid component and a cystic component, and on angiogram you see the tumor blush of a hypervascular mural nodule. Then von Hippel-Lindau syndrome is an autosomal dominant syndrome where hemangioblastoma is common. And this syndrome can be diagnosed if one of three criteria is fulfilled. Number one, you got multiple hemangioblastomas in the same patient. Like in this case, and you can see three hemangioblastomas in the cerebellum. And this is a large one, a smaller one, and a very small one. All these lesions show a cystic component and a mural nodule which is enhancing. The second issue for the diagnosis of von Hippel-Lindau syndrome is the presence of a single hemangioblastoma in a patient with family history of these hemangioblastomas or von Hippel-Lindau syndrome. Or you may get a single hemangioblastoma with visceral tumors in the same patient. And this is a von Hippel-Lindau syndrome because of multiple hemangioblastomas in the cerebellum. And you remember that the pilocytic astrocytoma does not occur in multiplicity, while the hemangioblastoma may be multiple. And one of the important issues is that sometimes you cannot appreciate the cystic component of the lesion because the mural nodule is almost occupying the whole cystic space. Then cerebellar metastases, like cerebral metastases, they are diagnosed based on multiplicity, based on the edema surrounding the lesions, based on the presence of a clinical finding of a primary malignancy. And the multiplicity, infra and supratentorial, is one of the helpful diagnostic criteria for the diagnosis of cerebellar deposits. And this patient had a renal cell carcinoma in the upper bowl of the left kidney with metastatic deposit to the cerebellar vermis. And here is a hemorrhagic cerebellar metastasis by CT, MRI T1, MRI T2, and MRI T1 post contrast. And you can see in the coronal image that this is not a single lesion, but there is another lesion in the right cerebral hemisphere. Then you remember from the lecture of intracranial calcification that calcium may occur in the basal ganglia, and in the cerebellum there are the dentate nuclei. And this is a case of basal ganglia calcification with a long list of differential diagnosis. And you can see calcium in the caudate, calcium in the lentiform, calcium in the thalamus, and calcium in the dentate nuclei. We came finally to the brainstem lesions, and they include hemorrhage, infarction, infection, tumors, calcium, and cysts. And in the brainstem, hematoma may occur, like in this case with a hyperdense lesion in the CT scan occupying the region of the bones, representing acute hematoma. Also, brainstem infarcts can occur within the area of the brainstem. As you can see, this diffuse hypodensity affecting the midbrain. And this is an example of a brainstem infarction, which is located in the upper part of the bones, and being an acute infarction, it shows restricted diffusion on diffusion weighted images. You remember some of the clinical notes previously mentioned about multiple sclerosis, and I have said that this disease in particular will be explained in details later on, and this is, as you all know, an autoimmune demyelinating process affecting women more than men, and the onset of this disease is usually between the age of 20 and 40 years. Uh, it presents by the presence of too many or multiple foci, or demyelinating foci of high signal in the T2 and the FLAIR images, particularly perpendicular to the ventricular wall and involving the region of the corpus callosum, as you can see here. And some of these lesions may occur in the brainstem as well as in the cerebellar hemispheres. Then you can see the high signal lesions in the FLAIR images, and here you can see an example of multiple sclerosis with plaques in the region of the brainstem as well as in the cerebellar hemisphere, together with focal lesions in the cerebral hemispheres as well. Then you see the a classic appearance of what's known as tumefactive MS, where you got big plaques similar to the tumors, and one of the characters of these lesions is the enhancing edge, which is not complete. And you can see here is the enhancement, and you can see the incomplete circle, which is almost characteristic for this type of tumefactive MS. And you remember that tuberculometer, we will explain this in the lecture of infections inside the brain. And you can see the tuberculomas appear like buttonhole or small abscesses showing thick enhancing margin and the central low signal part. And these are active tuberculomata surrounded usually by perifocal brain edema. Then we came to one of the important tumors occurring in the brainstem, which is the brainstem glioma. This glioma represents about 12 to 15% of the pediatric brain tumors, and it is usually of the anaplastic type or the glioblastoma type. The age incidence is around 3 to 13 years old, and the lesion is mainly located in the bones and may give metastatic CSF state. One of the commonest presentations is the cranial nerve pulses, especially affection of the abducent nerve. Then the tumor is usually hypodense on the CT scan, and if you inject the contrast, it does not enhance. And this is the difference between this section showed the normal appearance of the bones and the normal appearance of the fourth ventricle. But here you can see flattening of the anterior fourth ventricle by this hypodense expanding lesion representing the brainstem glioma. And this is another example of a brainstem glioma compressing and flattening the anterior part of the fourth ventricle, and it also extends through the middle cerebellar peduncle on the right side, infiltrating the right cerebellar hemisphere. And this is the hypodense lesion, which does not usually show enhancement, and in 50% of the cases it may show enhancement, which means aggressiveness of the tumor, and is categorized as glioblastoma multiforme if it shows some enhancement. Then this MRI T2 weighted image show one of the most characteristic features of brainstem glioma, which is exophytic extension of the tumor. And here you can see that the tumor extends exophytically, filling the prepontine cistern anterior to the basal artery, which is usually displaced posteriorly. And you expect from a brainstem lesion is to compress the basal artery, displacing it anteriorly against the dorsum celli. And this does not occur in cases of brainstem glioma because of this particular character for this tumor, where it can grow exophytically anterior to the basilar artery, displacing the artery more posteriorly. Then you can see the tumor, and you can see areas of necrosis in this T2 weighted image. And this is the T1 of the same case, and also the T1 post contrast, showing some enhancement in the tumor, meaning that it is an aggressive lesion and is categorized as glioblastoma multiforme. The tumor will show free diffusion on diffusion weighted images, and this is the T2 weighted image, and this is the flare, and you can appreciate this particular finding, which is exophytic extension of the tumor in the prepontine cistern. And this is the sagittal T1 weighted image before and the sagittal T1 weighted image after injection of contrast media, showing an infiltrating lesion enlargement, causing enlargement and swelling of the brain stem with foci of post-contrast enhancement, diagnostic of brainstem glioma. Brainstem metastasis can also occur, showing the same criteria as metastasis in the cerebellum and metastasis supratentorial. Metastases are diagnosed by multiplicity, by the considerable perifocal brain edema around the lesions, and by the known history of primary malignancy. And then we came to a lesion which affects the brainstem, known as osmotic demyelination syndrome. And this is known as central pontine myelinolysis or osmotic demyelination syndrome, which is presented in imaging as a central hyper intense lesion within the bones. And some changes similar to that in the bones may occur extrapontine in the basal ganglia as well as in the white matter. The lesions are usually bilateral and symmetric, and if you give contrast enhancement, they will not enhance. And this particular lesion is the sequelae of rapid correction of hyponatremia. Then the patient may become hyponatremic, usually post-operative or post-traumatic. Then the rapid correction of this hyponatremia will result in this particular syndrome, which is known as central pontine myelinolysis or osmotic demyelination syndrome. In the CT scan, you may not appreciate the lesion because of the faint hypodensity of the lesions in the bones as well as in the basal ganglia. The lesions will not show any contrast enhancement. Then in the T2 weighted image, you will see lesions central in the bones, and you may see also lesions in the basal ganglia, which is known as extrapontine myelinolysis. And if you perform the diffusion weighted images, there will be free diffusion of these lesions. And this is also a good example of the central pontine myelinolysis or the osmotic demyelination syndrome of this patient. Then you see faint high signal in the bones, and you can also see there is no diffusion restriction in this area. Another example of pontine and extrapontine myelinolysis in a patient operated for a pituitary adenoma. And the T1 weighted image, you cannot appreciate the lesions, and the T2 weighted image, you can see faint high signal in the upper part of the bones as well as in the lower part of the both temporal lobes. In the flare image, you can see the high signal here and also the high signal here, diagnostic of pontine and extrapontine myelinolysis. And I thank you very much.